Authors: Charles Deacon, Simon Brown, Fiona Jukes, David Lockie, Richard Lyon, Fiona Moore, Gavin Perkins, Mark Whitbread. 1. The Guideline Process. The process used to produce the Resuscitation Council, UK, Guidelines 2015 has been accredited by the National Institute for Health and Care Excellence. The guidelines process includes systematic reviews with grading of the quality of evidence and strength of recommendations. This led to the 2015 International Liaison Committee on Resuscitation, ILCR, Consensus on Cardiopulmonary Resuscitation and Emergency Cardiovascular Care Science with Treatment Recommendations. 1,2. The involvement of stakeholders from around the world, including members of the public and cardiac arrest survivors. Details of the guidelines development process can be found in the Resuscitation Council, UK, Guidelines Development Process Manual. These Resuscitation Council, UK, guidelines have been peer-reviewed by the Executive Committee of the Resuscitation Council, UK, which comprises 25 individuals and includes lay representation and representation of the key stakeholder groups. Back to top. 2. Summary of changes in pre-hospital resuscitation since the 2010 guidelines. The team approach is emphasized. The pre-hospital resuscitation team should ideally comprise 4 individuals, who between them undertake roles as team leader, manage the airway, and alternate in the delivery of chest compressions and assisting with vascular access and drug delivery. Simpler airway devices such as supraglottic airways, including the laryngeal mask airway and iGel, enable oxygenation and ventilation to be achieved rapidly. They should be used as part of a stepwise airway management pathway. Tracheal intubation should be attempted only by those with adequate training and only if simpler airways prove inadequate. There is no evidence that a period of CPR before defibrillation improves success rates, and solo responders arriving at a cardiac arrest should prioritize attaching a defibrillator and defibrillation if indicated. Mechanical chest compression devices are a reasonable alternative to high-quality manual chest compressions in situations where sustained high-quality manual chest compressions are impractical or compromise provider safety. The use of waveform capnography is emphasized not only to indicate correct placement of a tracheal tube in the airway, and not the esophagus, but also as a useful indicator of cardiac output and the effectiveness of chest compressions. A sudden increase in the end-tidal carbon dioxide, CO2, may be an early indicator of return of spontaneous circulation, ROSC. After ROSC is achieved, passive cooling is recommended in the pre-hospital phase. The patient should be transferred to the most appropriate hospital for their needs, and this may not always be the nearest hospital. For patients with ST segment elevation on the ECG, the optimal care pathway requires direct transfer to a hospital that can provide immediate primary percutaneous coronary intervention, PPCI, at all times. An arrangement should be in place to receive these patients directly into the cardiac catheterization laboratory. Back to top. 3. Introduction. The principles of basic and advanced life support are the same for the pre-hospital setting but can be limited by a combination of factors, including a lack of trained staff, the setting, on scene or during transport, equipment and drugs, and physical access to the patient. This section addresses specific pre-hospital issues that are not covered elsewhere in the Resuscitation Council, UK, Guidelines 2015. These guidelines should be read in conjunction with the Resuscitation Council, UK, Resuscitation Guidelines 2015, Association of Ambulance Chief Executives, AACE, and Joint Royal College's Ambulance Liaison Committee, JRCLC, UK Ambulance Services Clinical Practice Guidelines, 3 and Local Ambulance Service Protocols. All doses of drugs and fluids refer to those appropriate for adults. Doses for children and the newborn should be modified accordingly. Back to top. 4. Dispatcher-assisted CPR. Scripted telephone triage is used in the UK to grade the urgency of emergency calls to the ambulance service and dispatch appropriate resources. This is an integral part of the chain of survival for cardiac arrest. 4. Dispatcher-assisted CPR reduces the time to first chest compression in out-of-hospital cardiac arrest, OHCA. 5. Dispatcher-assisted CPR is considered beneficial and is now more practical with the widespread use of mobile phones, which enable the rescuer to receive instruction whilst staying with the victim. 6,7 and is enhanced with the hands-free speakerphone function. Telephone instructions to the caller, rescuer, on how to give CPR increases the rate of bystander CPR and reduces the time in starting CPR, with some evidence that this improves outcome from cardiac arrest. 7. Dispatcher-assisted recognition of cardiac arrest. In the UK, call handlers answering 999 calls generally have no medical training and read triage questions from a screen. The deviation allowed from the precise wording in the question or the advice supplied varies between dispatch systems. The wording of the questions and the instructions offered must be understood by both the caller and the dispatcher. Medical jargon must be avoided. Some systems allow the dispatcher flexibility in wording to clarify the meaning to the caller, but too much flexibility can cause ambiguity and delay starting dispatcher-assisted CPR. The recognition of cardiac arrest is difficult over the telephone and is made more difficult as the caller is often distressed, alone and scared. Absence of breathing in an unconscious person is a good indicator of respiratory arrest, but many people with cardiac arrest initially gasp, agonal breathing, and the lay rescuer can misinterpret this as breathing. 8 It is therefore considered better to ask if the victim is breathing normally instead of simply breathing. Some people with cardiac arrest will have an initial seizure when the heart stops. This can cause confusion and delay the correct diagnosis. Training of dispatchers should include the significance of agonal breathing. Dispatchers who understand this are more effective at recognizing cardiac arrest. Asking whether the person is a known epileptic can help reduce the risk of inadvertent CPR in a person having a seizure. 9. Dispatchers should be trained in the management of cardiac arrest in all age groups, so that they are familiar with the instructions that they are giving to the rescuer. Dispatchers should be trained to handle very distressed callers. Patients who are unconscious and not breathing normally should have the most rapid ambulance response possible. Dispatcher advice. Following identification of cardiac arrest, dispatchers provide CPR instructions to the caller. 10-12 This dramatically reduces the time to the first chest compression, compared with waiting for the arrival of an ambulance crew. However, delays in giving advice over the phone and/or poor quality CPR will limit these benefits. 12. Standardized dispatcher advice to bystanders is recommended to improve the prompt and correct recognition and treatment of cardiac arrest. If the phone has a speaker facility, the caller should be told to switch it to speaker, as this will facilitate continuous dialogue with the dispatcher, including, if required, CPR instructions. 13. Dispatcher-assisted compression-only CPR. Dispatcher-assisted CPR should be easy to describe and easy to perform correctly, assisted by the use of a metronome by the dispatcher to ensure correct compression rates. When an untrained bystander dials 999, the ambulance dispatcher should instruct him to give chest compression-only CPR while awaiting the arrival of trained help. Bystanders who are trained and competent in CPR with rescue breathing should continue to undertake this, but only if they are confident to do so without dispatcher support. Untrained rescuers receiving telephone advice are unable to do effective CPR combining rescue breaths and chest compressions. 14,15 Rescuers may also be more likely to start CPR if they do not have to provide mouth-to-mouth breaths. 16 Compression-only CPR is generally thought to be appropriate in most circumstances. In adults, dispatcher-assisted compression-only CPR produces better survival rates than conventional CPR. 11,17, A18 In children, Where 70% of out-of-hospital cardiac arrests are associated with hypoxemia, survival is improved if both chest compressions and rescued breaths are delivered. 19,20 After cardiac arrest in children with a primary cardiac cause, there is no difference in survival after compression only or conventional CPR. Either technique produces better survival rates than no CPR. 19,20 Dispatcher-assisted use of automated external defibrillators, DES. Community first responders, particularly in more rural areas, and public access to fibrillation schemes are important components of the initial response and should be established wherever possible. Registration of defibrillators with the local ambulance services is highly desirable so that dispatchers can direct CPR providers to the nearest. The Resuscitation Council, UK, Adult Basic Life Support and Guidelines recommend that in order to improve survival from cardiac arrest, all school children are taught CPR and how to use, and everyone that is able to should learn CPR. Defibrillators are available in places where there are large numbers of people, for example airports, railway stations, shopping centers, sports stadiums, increased risk of cardiac arrest, for example gyms, sports facilities, or where access to emergency services can be delayed, for example aircraft and other remote locations. Owners of defibrillators should register the location and availability of devices with their local ambulance services. Systems are implemented to enable ambulance services to identify and deploy the nearest available defibrillator to the scene of a suspected cardiac arrest. All out-of-hospital cardiac arrest resuscitation attempts are reported to the National Out-of-Hospital Cardiac Arrest Audit. www.org.ac.uk web link. The Resuscitation Council, UK, and British Heart Foundation have produced information endorsed by the National Ambulance Service Medical Directors Group about DES and how they can be deployed in the community, a guide to automated external defibrillators, DES. DES are safe and effective when used by laypeople, even if they have had minimal or no training. 21s may make it possible to attempt defibrillation many minutes before professional help arrives. Strengthening the community response to cardiac arrest by training and empowering more bystanders to perform CPR and by increasing the use of DES at least doubles the chances of survival and could save thousands of lives each year. 13,22 Each minute of delay to defibrillation reduces the probability of survival to hospital discharge by 10%. In the UK, fewer than 2% of victims have been deployed before the ambulance arrives. 23. Back to top 5. Pre-hospital cardiac arrest clinical care. Treatment on scene aims to identify and treat immediate life-threatening problems and achieve ROSC in those who have had a cardiac arrest. Remain on scene to achieve ROSC, unless reversible causes that cannot be dealt with on scene are identified and can potentially be treated in hospital. Make the decision to transport the patient to hospital as soon as the need for skills and interventions not available on scene is known. The deteriorating patient who cannot be stabilized on scene requires early recognition and transport to a suitable hospital, for example decompensated patient with penetrating trauma. Clinical staff must ensure they are competent and current in the skills that they use. This will be achieved through both training and clinical experience. The team approach to pre-hospital resuscitation. Resuscitation requires a system to be in place to achieve the best possible chance of survival. The system requires technical and non-technical skills, teamwork, situational awareness, leadership, decision-making. Allocation of roles. Appoint a team leader as early as possible. Ideally they should be a paramedic or clinician experienced in pre-hospital resuscitation. The team leader should assign team members specific roles, which they clearly understand and are capable of undertaking. This will promote teamwork, reduce confusion and ensure organized and effective management of resuscitation. Minimum of 4 trained staff is required to deliver high-quality resuscitation. This will necessitate dispatch of more than one ambulance resource. Ensure there is 360 degrees access to the patient, Circle of life. Position 1, airway. At head of patient, the person must be trained and equipped to provide the full range of airway skills. Position 2, high-quality chest compressions and defibrillation if needed, at patient's left side. Be prepared to alternate with the operator at position 3 to avoid fatigue. Position 3, high-quality chest compressions and access to the circulation, intravenous, intraosseous, at patient's right side. Position 4, team leader, stand back and oversee the resuscitation attempt, only becoming involved if required. The team leader should have an awareness of the whole incident and ensure high-quality resuscitation is maintained and appropriate decisions made. Effective command and control. Effective command and control of a cardiac arrest avoids raised voices. Commands not given clearly. Statements made into thin air. Open-ended communication. Ensuring high-quality CPR. The team leader must coordinate all roles and ensure that interruptions to chest compressions are kept to a minimum. Pauses in chest compressions should be planned by the team whilst chest compressions are ongoing. Interruptions during CPR are common and associated with worse survival. 13,24 Common causes of prolonged pauses in chest compression during CPR are advanced airway insertion, tracheal intubation, supraglottic airway, pulse checks and cardiac rhythm assessment, excessive hands-off time during defibrillation, airway management during CPR. As a general rule, no more is necessary than that which achieves an open airway sufficient to enable adequate oxygenation and ventilation. Although tracheal intubation has been considered the gold standard in airway management, outcome data, the difficulty of pre-hospital intubation and the risks of very significant morbidity and mortality, for example prolonged desaturation, unrecognized esophageal intubation, endobronchial intubation, have challenged this concept. 25,26 During CPR, clinicians should use the airway technique with which they are most experienced in order to provide adequate oxygenation and ventilation. Tracheal intubation in children should be avoided, unless the operator is an expert in this procedure in children. During CPR, the pause in chest compressions to insert an advanced airway, tracheal tube or supraglottic airway, should be less than 5 seconds. The optimal airway technique for cardiac arrest is unknown and is likely to depend on the skills of the operator, the anticipated pre-hospital time and patient-dependent factors. In the UK, a large pre-hospital trial is ongoing, Airways 2 trial www.airways2.bristol.ac.uk. Stepwise airway care during CPR. In practice, several airway interventions, for example no airway interventions, mouth-to-mouth, bag mask, supraglottic airway, tracheal intubation, and devices are used in a stepwise manner during CPR and after ROSC. 27 Rescuers should use the skills in which they are proficient. Stepwise airway care provides a progressive approach to obtaining and maintaining an open airway and adequate oxygenation and ventilation. During a cardiac arrest, it is very important to maintain high-quality chest compressions with minimal interruption for airway interventions. Start with a head tilt, chin lift or jaw thrust, using the latter in patients at risk of cervical spine injury. Simple airway adjuncts. A simple airway adjunct may assist opening the airway. Oropharyngeal airways are suitable for unresponsive patients, but will not be tolerated by those who are semi-conscious. If the patient's level of consciousness subsequently improves, remove the airway if it is not being tolerated, in order to prevent gagging and vomiting. An esopharyngeal airway may be better tolerated in a patient with an obstructed airway who is not completely unresponsive and is also suitable for a patient with trismus when the mouth cannot be opened. Supraglottic airways, SGAs. There are several different SGAs, but they all sit above the larynx, covering the vocal cords and are simpler and quicker to insert than a tracheal tube. They can be inserted with minimal interruption to chest compressions. SGAs are a good alternative to bag mask ventilation and are associated with less aspiration of gastric contents. 28 In the UK, the two commonest used devices are the laryngeal mask airway, LMA. A number of variations with differing performance are available. iGel may be easier and quicker to insert than the LMA because of the absence of an inflatable cuff. Leak pressures are comparable to that of the LMA. Tracheal intubation. The tracheal tube is the most challenging of all airway devices to insert successfully and requires adequate initial training and ongoing practice. At least 50 attempts are required to achieve a 90% success rate, and most paramedics are unlikely to have sufficient clinical experience to maintain their skills. 25 A recent study of trauma patients documented an overall 64% tracheal intubation success rate and an 11% unrecognized esophageal intubation rate. 29 In a recent study of 628 patients with AHA in Scotland, intubation attempts were successful in 91%, but significant complications occurred in almost 9%. There is no evidence that outcome from AHA is improved by tracheal intubation, and several studies have suggested that simpler airway techniques during CPR, that is bag mask, SGA, result in at least as good, if not better, patient outcomes. 2,24 Tracheal intubation is safely tolerated only in patients who are unresponsive to stimulation, whether through their underlying condition or achieved through the use of anesthetic drugs. Most patients therefore who are amenable to non-drug assisted tracheal intubation are those who have suffered a cardiac arrest. In these patients, tracheal intubation, or any airway maneuver, should not impede the delivery of uninterrupted chest compressions or delay defibrillation. Pre-hospital drug-assisted intubation should be undertaken only by those who undertake the procedure regularly within an appropriate clinical governance framework, with adequate audit and review of outcomes. Tracheal intubation, practical considerations. Views of the larynx are often suboptimal because of restricted neck movement, jaw opening, poor lighting, vomit and other airway secretions, poor patient positioning, and difficult access to the patient. The following can help achieve safe and successful pre-hospital tracheal intubation. Ensure 360 degrees access around the patient where possible. Ensure all the necessary equipment by the patient as a kit dump. Use a checklist to check all equipment is available, allocate roles and make a rescue plan if initial attempts at intubation or ventilation fail. Patient positioning. Whenever possible, place the patient supine on an ambulance trolley, preferably one that tips head down in case of vomiting. Intubation is easier when the trolley is at the knee level of the person managing the airway. Do not routinely use cricoid pressure for tracheal intubation during CPR. In many cases the patient will have already aspirated, and cricoid pressure will often make tracheal intubation more difficult. Use a bougie, if necessary, over which a tracheal tube can be railroaded. A bougie should always be available. Choose the correct sized laryngoscope blade. Generally a size 4 Mac blade can be used for most adults. Video laryngoscopy can help with difficult intubation. A variety of devices are available but require specific training in their use. A good view of the cords on the video screen does not mean tube placement will be easy. Secure the tracheal tube immediately after insertion. Adult males, 22 to 23 centimeters. Adult females, 21 to 22 centimeters, using a tie, commercial clamp or tape. A tie around the patient's head or neck can decrease venous drainage of blood from the head and brain and increase the intracranial pressure. Do not over-tighten the tie and consider using tape in patients where intracranial pressure may be raised, for example head injury. The same is true for securing SGAs. When moving the patient, hold the tracheal tube, even when it is secured. Regularly check the tracheal tube position during transit to ensure that it has not dislodged. During CPR, aim to minimize the interruptions to chest compressions for tube placement to less than 5 s. This means doing the initial laryngoscopy whilst compressions are ongoing, a brief pause to optimize the view and pass the tube, and then restarting compressions. Plan actions and pauses whilst compressions are ongoing. Tracheal intubation, complications. There are several significant complications associated with tracheal intubation. Hypoxemia, pre-oxygenate the lungs before and between intubation attempts. Unrecognized esophageal intubation, always use waveform capnography to exclude esophageal intubation and continuously monitor the position of the tracheal tube. Endobronchial intubation, if the tracheal tube is inserted too far, the orientation of the bronchi is likely to result in the tracheal tube passing into the right main bronchus. Insert the tracheal tube to no more than the appropriate length, listen to breath sounds in both axillae, and ensure both lungs are ventilated. Monitor the position of the tube during transit. Cricothyroidotomy. Cricothyroidotomy is used when efforts at oxygenation and ventilation fail, for example can't intubate, can't ventilate, CICV. It may be performed using a large bore needle for jet insufflation or by incising the cricothyroid membrane and inserting a tracheal tube. Surgical cricothyroidotomy has a higher success rate and provides more effective ventilation than needle cricothyroidotomy because of the larger airway that can be inserted. Needle cricothyroidotomy is generally of limited effectiveness, but preferable to surgical cricothyroidotomy in children up to about 12 years of age because it is anatomically easier to perform, with less potential damage to the larynx. Lung aspiration of gastric contents. Aspiration of regurgitated gastric contents into the lungs is common in patients after cardiac arrest and is exacerbated by stomach inflation during rescue breaths. Regurgitation occurs in approximately 1/3 of ACA, often before the arrival of ambulance personnel. 31 Pulmonary aspiration after cardiac arrest has been documented in 20% of survivors, 32 although the impact on outcome is unclear. Airway management is challenging with whichever airway device is used. In patients who have regurgitated gastric contents, use suction and, if possible, left lateral tilt and a head-down position. This may not be feasible during CPR. Gentle ventilation with a bag mask, sufficient to just enable the chest wall to rise, minimizes airway pressure and reduces gastric inflation. SGA insertion reduces gastric inflation compared with a bag mask, and tracheal tube insertion abolishes it completely. Use a nasogastric tube to decompress the stomach, once the airway and ventilation have been established. Breathing. Breathing has two main functions, to deliver oxygen to the cells, and to remove waste products of respiration, CO2. Initial management. Having opened the airway, the first priority is to rapidly assess, identify and treat reversible causes of impaired breathing. Use the look, listen and feel approach to assess for breathing. Expose the chest sufficiently to look for signs of injury, chest wall expansion and asymmetry between each side. Listening with a stethoscope is difficult in the noisy pre-hospital environment, and the use of ultrasound may assist in the diagnosis of a pneumothorax. Feeling for equal chest wall expansion, bony injury or surgical emphysema is useful, the latter in most cases being pathognomonic of a pneumothorax or rupture of a large airway. Use pulse oximetry to assess oxygen saturation in patients with a cardiac output. In the pre-hospital setting, the combination of cold peripheries and a low cardiac output can make pulse oximetry unreliable. If a pulse oximeter probe placed on a finger fails to measure the oxygen saturation, use other anatomical sites, for example toes, nose, earlobes or tongue. Inspired oxygen concentration, FiO2. The optimal blood oxygen value during CPR and after ROSC is unknown. Hypoxia, low tissue oxygen levels, is harmful, and some evidence suggests that hyperoxia, high tissue oxygen, can also be harmful. 2,33. During CPR aim to deliver 100% oxygen. After ROSC aim for NSPO2 of 94 to 98%. Give high flow oxygen until the oxygen can be reliably measured to enable titration of the FiO2. Oxygen should only be used in newborn resuscitation if the baby has failed to respond to ventilation with air, and titrated to achieve the target oxygen saturation. See resuscitation and support of transition of babies at birth. 34,35. Tension pneumothorax. Decompress a tension pneumothorax as soon as it is recognized. Focused chest ultrasound can be used to supplement clinical signs to diagnose a pneumothorax. A tension pneumothorax requires immediate treatment. Common causes include penetrating trauma or the sharp edge of a fractured rib. Less commonly, a pneumothorax can be caused by high airway pressures as seen in acute severe asthma, spontaneous rupture of a lung bulla, sudden compression of the chest wall against a closed glottis, or barotrauma from an explosion. All pneumothoraces begin as a simple pneumothorax, when the intrapleural pressure is minimal and there is no significant respiratory or cardiovascular compromise. This transitions to a tension pneumothorax as air progressively builds up in the pleural cavity, and is accelerated by positive pressure ventilation. By the time physiological compromise is apparent, the tension is significant and will inevitably result in sufficient respiratory and cardiac compromise to cause a cardiac arrest unless quickly treated. The aim of prehospital management is to relieve the tension and convert a tension pneumothorax to a simple pneumothorax. The latter is generally not life-threatening and will enable the patient to be conveyed to hospital for definitive care. Management follows a stepwise approach. The quickest and simplest initial treatment is needle decompression in the second intercostal space in the mid-clavicular line or in the fifth intercostal space in the mid-axillary line. Needle decompression is only a temporary measure because the cannula may become blocked with blood, kinked or work its way out of the tissue. Repeated needle decompression may be necessary if a definitive chest drain has not been inserted and the patient deteriorates again. In patients close to a destination hospital, needle decompression may be sufficient to deliver the patient before the tension pneumothorax recurs. In patients with longer transit times, who are breathing spontaneously, a chest drain incorporating a one-way valve may need to be inserted, usually in the fifth intercostal space in the mid-axillary line. The fifth intercostal space may be difficult to locate and a chest drain placed too low risks catastrophic complications. Anatomically, the base of the axilla approximates to the fifth intercostal space and chest drains should not be placed lower than this boundary. Thoracostomy, fifth intercostal space in the mid-axillary line, in patients receiving positive pressure ventilation with a tension pneumothorax. A chest drain can then be inserted after hospital arrival. It is common for blood to be present within a pneumothorax, but no specific additional treatment other than adequate volume replacement is necessary for this complication. A hemotrax does not need to be drained in the prehospital environment. The presence of blood in the intrapleural cavity can tamponade and slow further bleeding, and release of this blood through a chest drain risks cardiovascular collapse. Ventilation. Avoid hyperventilation during CPR and after ROSC. Aim for a normal PaCO2 in patients with ROSC. Waveform capnography can be used to help achieve this. Hyperventilation reduces venous return to the heart and leads to hemodynamic instability, particularly in patients with hypovolemia and shock. In those with ROSC following cardiac arrest, hyperventilation can cause rearrest. Positive end expiratory pressure, PEP, also adds to the intrathoracic pressure to exacerbate this effect and should be kept to a minimum, if used at all, particularly in patients with head injury where it decreases cerebral perfusion pressure. Hyperventilation can result from an excessive tidal volume, respiratory rate, or both. The use of a mechanical ventilator may enable better control of minute volume and minimize hyperventilation, as well as freeing a rescuer from this task. Minute volume, tidal volume 10 respiratory rate, determines PaCO2. The optimal value is not known, but hypocarbia and anything more than mild hypercarbia appear detrimental to outcome. Aim for a PaCO2 within a normal range, even in a patient with head injury, where hyperventilation-induced vasoconstriction may actually worsen cerebral oxygen delivery. Circulation. Chest compressions during CPR. Start chest compressions as soon as cardiac arrest is confirmed. Full guidance on chest compression technique is provided in Adult Basic Life Support and Automated External Defibrillation. Place the hands in the center of the chest, which is the middle of lower half of the sternum. Compress the chest to a depth of 5 to 6 centimeters. Compress the chest at a rate of 100 to 120 minutes -1. Ensure full release of the chest between chest compressions by avoiding leaning on the chest. Perform CPR on a firm surface if possible. Soft surfaces, for example mattress, make it difficult to estimate how deep the chest is being compressed and can lead to undercompression. Minimize interruptions in chest compressions. Alternate 30 compressions with 2 ventilations. If the patient's trachea is intubated, provide continuous chest compressions at 100 to 120 minutes -1 with ventilations 10 minutes -1. In patients with an SGA in situ, continuous ventilations may be possible, but if visible chest rise is not seen with each breath, give 2 ventilations after every 30 compressions. Try to change the person doing chest compressions every 2 minutes. Ensure the minimum of delay during the changeover. CPR monitoring, feedback and prompt devices. CPR feedback and prompt devices, for example voice prompts, metronomes, visual dials, numerical displays, waveforms, verbal prompts, and visual alarms, should be used when possible during CPR training. Their use during clinical practice should be integrated with comprehensive CPR quality improvement initiatives rather than as an isolated intervention. CPR monitoring, feedback and prompt devices enable the CPR provider to receive real-time objective feedback on the quality of CPR. These devices have been evaluated in several clinical studies that support their utility to improve the quality of CPR delivered. 36,37. Mechanical chest compression devices. Do not use automated mechanical chest compression devices routinely to replace manual chest compressions. Automated mechanical chest compression devices are a reasonable alternative to high-quality manual chest compressions when sustained high-quality manual chest compressions are impractical or compromise provider safety. 2,24. Avoid interruptions to CPR during device deployment. Healthcare personnel who use mechanical CPR should do so only within a structured, monitored program, which should include comprehensive competency-based training and regular opportunities to refresh skills. In 2006, Drkulk highlighted the absence of strong evidence supporting the use of mechanical CPR devices and recommended against their purchase for routine use pending results from large clinical trials. www.drkulk.org.uk web link. This position was reiterated by a statement from the Resuscitation Council, UK, in 2013. There have now been 3 large randomized controlled trials, RCTs, enrolling 7,582 patients that have shown no clear advantage for the routine use of automated mechanical chest compression for ACA using the Lund University Cardiac Arrest System, Lucas, 38,39 and Auto Pulse device. 40 Ensuring high-quality chest compressions with adequate depth, rate and minimal interruptions, regardless of whether they are delivered by machine or human, is important. 41,42 Mechanical compressions usually follow a period of manual compressions. Interruptions to chest compression must be minimized and delays in defibrillation avoided during transition from manual to automatic mode. 43 The use of training drills and pit crew techniques for device deployment are suggested to help minimize interruptions in chest compression. 44-46 If an ambulance service has already purchased mechanical chest compression devices, we suggest that their use is limited to those patients requiring transfer to hospital with ongoing CPR or prolonged CPR. Such patients might include patients with VF, private and suspected acute coronary syndrome, refractory to 5 shocks, persistence or recurrence of fibrillation, in whom a decision is made to transport to a heart attack center for emergency coronary angiography and, if indicated, percutaneous coronary intervention. Defibrillation. Attempt defibrillation when a shockable rhythm is identified according to ALS guidelines. See Advanced Life Support. Defibrillation is one of the few interventions that improves outcome from sudden cardiac arrest, but its application is time critical. Each minute of delay to defibrillation reduces the probability of survival to hospital discharge by 10%. 13. Safe use of oxygen during defibrillation. Ensure any mask and oxygen tubing is more than 1 meter from the patient's chest when attempting defibrillation. If the patient has a tracheal tube or SGA inserted, leave the breathing system connected, or disconnect and ensure it is more than 1 meter from the patient's chest. Oxygen is one of the 3 components of the fire triad: oxygen, ignition, source of combustion, and represents a significant fire risk during defibrillation. In 24% ambient oxygen, the rate of combustion doubles, and increases tenfold in 30% ambient oxygen. High ambient oxygen concentrations from ventilation circuits have caused fatal fires and explosions. Oxygen can be present in concentrations above ambient due to supplementary oxygen or from an oxygen-powered Lucas external chest compression device. 47. Pads versus paddles. Use self-adhesive defibrillation pads for pre-hospital defibrillation. Self-adhesive defibrillation pads provide better contact with the undulating skin surface, reducing the risk of arcing between electrodes, with the concomitant risk of fire, and result in a lower transthoracic impedance than that achieved with paddles, improving the transmyocardial current with some waveforms. Defibrillation pad positioning. When the standard anterolateral defibrillation pad position is not feasible, biaxillary pad or antero-posterior pad placement is an acceptable alternative. CPR before defibrillation. When attending as a solo responder, immediate assessment of the rhythm and defibrillation when indicated, should take precedence over airway or breathing interventions. Immediate defibrillation should always be performed in patients where a shockable rhythm is identified on the ECG, irrespective of the amplitude. There is no convincing evidence that a period of chest compressions before shock delivery improves survival from cardiac arrest with a shockable rhythm, even when the cardiac arrest is unwitnessed. 24. Hands-on defibrillation. Do not touch the patient during shock delivery. Providing continuous chest compressions during the delivery of the defibrillation shock, hands-on defibrillation can minimize peri-shock pause and enable continuation of chest compressions during defibrillation. The benefits of this approach are not proven and further studies are required to assess the safety and efficacy of this technique. Standard clinical examination gloves, or bare hands, do not provide a safe level of electrical insulation. 48. Defibrillation in difficult situations. There are several situations in which the rescuer is at greater risk from leakage current and subsequent injury from accidental electrocution during defibrillation. However, in patients with a shockable rhythm, immediate defibrillation is potentially life-saving. Defibrillation on wet surfaces. Defibrillation of a patient on a wet surface is safe providing the rescuer is not in contact with the patient. If the patient is wet, ensure that self-adhesive defibrillation electrodes make good contact. If necessary, dry the patient's skin. Poor contact risks ineffective defibrillation and arcing between electrodes. Defibrillation on metal surfaces. Defibrillation of a patient on a metal surface is safe, providing the rescuer is not in direct contact with the patient. Metal surfaces ensure that any leakage current is completely conducted through the metal and away from any bystanders or rescuers. Defibrillation in flight. Certification of the defibrillator and aircraft for in-flight defibrillation should be discussed with the aircraft operator to ensure safety of the aircraft operating systems. Defibrillation in an aircraft or helicopter is safe because the metal surface in contact with the patient ensures that any leakage current is conducted away from the rescuers. The use of oxygen in the confined space of a cabin may result in raised ambient concentrations of oxygen and a theoretically increased risk of fire, although to date there are no case reports of an aircraft fire caused by defibrillation. It would be prudent, however, to keep oxygen use to a minimum in aircraft cabins and other confined spaces. Vascular access. During CPR chest compression, defibrillation and airway interventions take priority over vascular access. Peripheral intravenous, 4, cannulation is the preferred option for vascular access. Intraosseous, IO, access is an alternative option. Obtain 4 access if this has not been done already. Peripheral venous cannulation is quick and relatively easy and is preferable to central venous access as the initial cannulation site. Although peak drug concentrations are higher and circulation times are shorter when drugs are injected into a central venous catheter compared with a peripheral cannula, insertion of a central venous catheter requires interruption of CPR and is associated with several potential complications. Drugs injected peripherally must be followed by a flush of at least 20 milliliters of fluid and elevation of the extremity for 10 to 20 s to facilitate drug delivery to the central circulation. Some services recommend that clinicians make no more than 2 attempts at gaining 4 access, max 2 in closing parenthesis. If 4 access is considered too difficult or cannot be established, consider gaining IO access. Follow the instructions for the intraosseous device used. Several studies indicate that IO access is safe and effective for fluid resuscitation, drug delivery and induction of general anesthesia. Continuous waveform capnography during CPR. Waveform capnography must be used whenever tracheal intubation is undertaken. Waveform capnography may also be considered for patients ventilated via an SGA, although end-tidal CO2 values can be less reliable because of leaks around the cuff during chest compression. The role of waveform capnography during CPR includes ensuring tracheal tube placement in the trachea, see above, monitoring ventilation rate during CPR and avoiding hyperventilation, monitoring the quality of chest compressions during CPR. End-tidal CO2 values are associated with compression depth and ventilation rate, and a greater depth of chest compression will increase the value. 49 Whether this can be used to guide care and improve outcome requires further study. 50 Identifying ROSC during CPR. An increase in end-tidal CO2 during CPR can indicate ROSC and prevent unnecessary and potentially harmful administration of adrenaline in a patient with ROSC. 53 If ROSC is suspected during CPR, withhold adrenaline. Give adrenaline if cardiac arrest is confirmed at the next rhythm check. Prognostication during CPR. Precise values of end-tidal CO2 depend on several factors including the cause of cardiac arrest, bystander CPR, chest compression quality, ventilation rate and volume, time from cardiac arrest and the use of adrenaline. Values are higher after an initial asphyxial arrest, with bystander CPR and decline over time after cardiac arrest. 50, 54, 55 Low end-tidal CO2 values during CPR have been associated with lower ROSC rates and increased mortality, and high values with better ROSC and survival. 50, 56, 57 The inter-individual differences and influence of cause of cardiac arrest. The problem with self-fulfilling prophecy in studies, our lack of confidence in the accuracy of measurement during CPR, and the need for an advanced airway to measure end-tidal CO2 reliably limits our confidence in its use for prognostication. The Resuscitation Council, UK, Recommends that a specific end tidal CO2 value at any time during CPR is not used alone to stop CPR efforts. End tidal CO2 values should be considered only as part of a multimodal approach to decision-making for prognostication during CPR. Refractory out-of-hospital cardiac arrest. A few patients who present in VF, private are difficult to treat and can have persistent VF. Private in such cases, consider changing the electrode position, that is move from the standard anterior lateral to an anterior posterior or biaxillary position. Recurrent episodes of VF occur in most patients who present with a shockable rhythm, even after it is successfully cardioverted. VF recurs in 50% of patients within 2 minutes of successful termination and in 75% of patients during the entire cardiac arrest. Give amiodarone, 300 mg for, after 3 defibrillation attempts, irrespective of whether those episodes are concurrent or separate. Should the patient remain in VF, inject amiodarone as directed by the ALS guidelines and transport the patient as soon as possible, with ALS and defibrillation continued en route. Defibrillation and performing effective chest compressions whilst moving these patients to the ambulance and then to hospital is difficult. If necessary, stop the ambulance while further therapy is given. Mechanical chest compressions should be considered for transfer. Disability, neurological issues. Do not use the presence of fixed dilated pupils during CPR to determine the chances of successful recovery from cardiac arrest. Neurological assessment while a patient is in cardiac arrest and receiving ALS, including the presence of fixed dilated pupils, does not provide any guidance on whether the outcome of resuscitation will be successful in terms of neurological recovery. Prehospital neonatal, less than 28 days of age, resuscitation. The resuscitation of a newborn in the community is invariably unexpected as high-risk deliveries are usually planned to take place in hospital. The increasing numbers of home births may result in more unexpected cases of neonatal resuscitation. The resuscitation of a newborn in the community essentially follows that undertaken in secondary care. See resuscitation and support of transition of babies at birth. 34,35 Summon emergency help early if there is any doubt about the well-being of the baby. Key steps include: minimize delays on scene. Alert the hospital to the impending arrival of the baby and mother. The mother and baby will require separate vehicles if the baby requires resuscitation. Remember to cut and clamp the cord. Keep the baby warm. Dry the term or near-term infant, remove the wet towels, and cover the infant with dry towel. Significantly preterm infants and those requiring resuscitation are best placed, without drying, into polyethylene wrapping. Food-grade plastic bags can be useful for this. 58,59. In infants of all gestations, the head should be covered with an appropriately sized hat. Babies who do not need resuscitation may be moved with the mother, and skin-to-skin contact with the baby and mother covered will help to keep the baby warm. Monitor the baby's breathing in transit. If the baby requires assisted ventilation, bag mask ventilation is preferred. Tracheal intubation is generally avoided because of the high likelihood of initial tube misplacement or tube dislodgement during transfer. Tiny tubes also block easily, and it is difficult to detect this in a small baby, especially if it is wrapped up in the back of an ambulance. The procedure inevitably causes delay in transfer, and the exposure required allows the baby to become cold. Most babies, even those born prematurely, will respond to effective mask ventilation. Start resuscitation with air, and give supplementary oxygen guided by pulse oximetry. See resuscitation and support of transition of babies at birth. Prehospital resuscitation in children. Cardiac respiratory arrest occurs less frequently in children compared with adults, hence both healthcare professionals and lay people are less likely to be involved in pediatric resuscitation. Most cardiac respiratory arrests in children are not caused by primary cardiac problems but secondary to other causes, mostly respiratory insufficiency. The priority with pediatric resuscitation is therefore usually to reoxygenate the child. See the sections on pediatric basic life support and pediatric advanced life support. Specific considerations include: children are likely to have severe underlying illness or injury that can only be managed adequately in hospital, and it is therefore particularly important not to delay on scene. Bag mask ventilation is the recommended first-line method for achieving airway control and ventilation in children. Supraglottic airways may provide a useful alternative when bag mask ventilation is not possible. Tracheal intubation is seldom indicated unless an individual with appropriate skills is able to perform the procedure. Even then, the benefits must be weighed up carefully, as it may prolong the time on scene. The journey time to the hospital, skills available at the scene, and clinical condition of the patient, including the risk of aspiration, should be considered. Difficulties with ALS procedures, for example establishing vascular access, must not delay the transfer of the child to hospital. Continue good quality BLS as the priority. Attempt ALS procedures en route if practical, stopping briefly only if essential, for example while attempting cannulation. Use pediatric pads for defibrillation of children under 8 years. If these are not available, adult electrodes placed in an anteroposterior orientation will suffice. Use of defibrillators in a manual mode is optimal, but where only an automatic mode is available, AED, it is still preferable to analyze the rhythm and deliver a shock if prompted to do so rather than withholding defibrillation. For single responders, opening the airway and providing effective ventilation takes priority over attaching a defibrillator. Gaining rapid vascular access in children is often quickest using an intraosseous needle. This should be used in preference to an intravenous cannula unless a suitable site for venous cannulation is immediately apparent. Children become hypothermic easily because of their large surface area to volume ratio. It is important to keep them as warm as possible before, and during, transfer. Resuscitation in special situations. Drowning. In the UK, there are approximately 350 accidental deaths from drowning each year. Drowning is commonest in males aged 20 to 30, and occurs mostly in inland waters, for example lakes, rivers, and during summer months. Water rescue. Whenever possible, bystanders should attempt to save the drowning victim without entry into the water. Talking to the victim, reaching with a rescue aid, for example stick or clothing, or throwing a rope or buoy and rescue aid may be effective if the victim is close to dry land. Rescue can present significant risk to the rescuer, but a sensible risk assessment is necessary to ensure that potentially survivable victims are rescued promptly. If entry into the water is essential, take a buoy and rescue aid, flotation device or boat. It is safer to enter the water with 2 rescuers than alone. Submersion durations of less than 10 minutes are associated with a very high chance of a good outcome, and submersion durations of more than 25 minutes are associated with a low chance of good outcome. In the UK, Combined Emergency Services Guidance recommends review of search and rescue efforts at 30 and 60 minutes from when the emergency services arrive on scene, Figure 1. Extended rescue efforts up to 90 minutes may be appropriate for children or those submerged in icy cold water, although the protective effects of extreme hypothermia,